Hi, I'm Dr. Andy Evans, Deputy Director for Clinical Services at the Rutgers Cancer Institute and RWJ Health, and I'm very happy to be here at the 66th Annual American Society of Hematology, or ASH meeting. And I'm really pleased to have Dr. Joanna Rhodes here, the Director of our Lymphoma program at the Cancer Institute, as well as the Oncology Service Line. And she has a busy meeting. She's involved with multiple presentations. In fact, 2 poster presentations tonight that I want to talk to you about. And Dr. Rhodes, you've done an amazing job over the last few years, several years, of building a strong reputation, especially in the field of CLL, SLL. So maybe tell us about the first one, and where we think about all the different treatment agents. How do we sequence them, and what's the secret sauce?
It's a great question. The field of CLL has definitely changed over the last decade, really using less chemoimmunotherapy, and with the approval of covalent BTK inhibitors and BCL2 inhibitors, and now non-covalent BTK inhibitors as well. But the question is, when you have so many wonderful options, what should you be doing first? What should you be doing second? How are you really going to maximize our survival for our CLL patients? This study used Flatiron data to look to see what are the most common treatment sequences in the first and second and third line settings, and really starting to look not just at progression-free survival, but overall survival, which truly is the endpoint that means the most when I think about sequencing. Is, am I doing something first that's going to work for a shorter period of time in the second line? How do we do these? And so what we found is that there are 16 dominant treatment sequences, and while that's a lot of different sequences, there's a lot of different ways to break this down. Anything that really did not involve a targeted agent, meaning didn't involve a BCL2 inhibitor or a covalent BTKI, led to a shorter overall survival, particularly for patients that received monoclonal CD20 monoclonal antibodies as single agents, followed by chemoimmunotherapy or chemoimmunotherapy to chemoimmunotherapy. To me, the key takeaway from this is that chemoimmunotherapy is truly inferior in terms of an overall survival benefit for our patients, and we really need to be getting it out of the clinics for our patients with CLL.
That's great, and I know you're the lead author on this, and we always talk about real world, which can have different shapes or sizes. Obviously, clinical trials are critical, they're granular, they help get drugs approved, but we know patients aren't always eligible for those, and this is, when we say real world with using the Flatiron database, this is all comers, right?
Yes, this is all comers. So Flatiron takes into account patients with Medicare, Medicaid, commercial insurance. The median age on this study was in their 70s. So again, really actually mirrors what we see in our clinic. The average median age on clinical trials for CLL is between 65 and 68. But the median age of diagnosis for CLL is actually 70, and most patients don't necessarily need to start treatment right when they're diagnosed. So we're really looking at patients initiating therapy 73, 74, 75, and even later on. And so understanding, how these patients do with our targeted agents who may not have been represented in clinical trials, I think is so important.
That's great. And obviously the tip of our spear for treating many, if not all, blood cancer, of course, is effectiveness, obviously quality of life, survival, as well as tolerability. But we also want to think of cost, and I know you're senior author on a separate cost analysis, right?
Yes, so again, in the frontline setting, we have 3 different covalent BTK inhibitors that are approved for both frontline and relapse refractory CLL. We have ibrutinib, which was first in class, and then the second generation inhibitors, acalabrutinib and zanubrutinib, most recently was approved. The question is, when you're using a continuous therapy, BTK inhibitors are given in a treat to progression model, whether it's for progression, stopping for an adverse event. Sometimes we even can stop for patient preference depending on the clinical scenario. What does that cost look like, and how does that look in particularly for Medicare patients, and what's the cost of the system? And it's not taking into account so what we were able to show is that it takes into account multiple factors. So the cost of the drug is one of them. And so actually, acalabrutinib ended up being cheaper than ibrutinib in terms of just a monthly cost. But then when you think about cost analysis, is also what's the side effect profile and how much are side effects actually costing the healthcare systems. And what we found was that acalabrutinib actually was cheaper than ibrutinib and zanubrutinib from a side effect profile cost. So this is really interesting data. I think it's important when we're thinking about, our healthcare system as a whole, what are we doing, and what's the total cost of the system, because these are not cheap drugs and patients stay on them for years. The median progression-free survival from the Elevate-TN study for acalabrutinib is over 6 years.
And you just said it, looking at the whole, really holistic, of course, the science, but also cost and everything. We want to make sure that favorably helps our patients. And thankfully, Rutgers and RWJ Barnabas is happy to be at the leading edge. Thank you so much. Have a great meeting.
Thank you so much, Dr. Evans.